Good evening. Welcome to the Next Gen Forum organized by the Young Internist Hub of Sri Lanka College of Internal Medicine. So, we have done 6 Next Gen Forum so far, and this is going to be the 7th Next Gen Forum for this year and will be the last Next Gen Forum that we are conducting for this year. Today, we have a young internist talking to you on post-viral arthritis, clinical spectrum, and current evidence. To start with the forum, let me cordially invite Professor Priyamali Jayasekara, the Vice President of Sri Lanka College of Internal Medicine, to welcome the gathering. Over to you, Madam.
Thank you, Sahan. Good evening, everyone. Let me welcome all of you for the Next Gen Forum on behalf of Dr. Krishanta Jayasekara, President, Sri Lanka College of Internal Medicine, who couldn't join today because he's attending some other important event. So the Next Gen Forum is a very special forum for the young internist. The specialty of this is actually the peers for peers. The physicians are doing this, the enthusiastic and knowledgeable physicians. They are talking about what they're passionate about. Especially these people are our future. And with these talks, we are addressing our own peers as well as the rest of the medical fraternity. And as Sahan said, this is the last one and the 7th one of the Next Gen Forum of the year. So at the outset, I would like to thank Sahan, Dr. Sahan Mendis, our joint secretaries, who is passionately organizing this whole year without tiring or anything. Like he's been now one of our dynamic secretaries. And also to the Gets Pharma, who is sponsoring all these years. And Udari, thank you very much. And I think Sahan will introduce you to the forum, and we hope we will get a very good feedback and very good lecture for today, because the kind of a very current topic here. Thank you, Sahan. Over to you.
Thank you, Madam. So, before we move on to the lecture, I would like to give you, the audience, some housekeeping messages because now during this lecture you may have questions. So if you have any questions, so we will have a Q&A session at the end of the lecture. So during the lecture, if you come across any questions, you can post or mention the questions in the Q&A box. At the end of the session, we will take over these questions for discussion. And even at during the Q&A session, so you can forward your questions through the Q&A box. So the moderator or the speaker will take over the questions for discussion. And as you all know, we are offering CPD points for the participants of this forum. So in order to obtain CPD points, you will have to fill a Google form and to provide your details so that we can send the CPD certificate as an e-certificate to your email. So there will be a QR code shared at the end of the lecture and during the Q&A session. You can scan the QR code and access the Google form and give your details. So you will have a CPD certificate sent to your email, but it will take about 2 weeks for you to have the CPD certificates. And at the same time, we will share a Google link for the same Google form in the chat box. You can also click if you can't scan the QR code, you can click the Google link and access the Google form and provide your details to obtain the CPD certificate. So that's about the housekeeping messages. So next, move on to the today's topic. So let me introduce our speaker today, Dr. Udari Kaushalya Egodage. MBBS, MD in medicine, a consultant physician and senior lecturer at the Faculty of Medicine, University of Ruhuna, Sri Lanka. Dr. Udari earned her MBBS from the Faculty of Medicine, University of Colombo, and her MD in medicine as well. Dr. Egodage is a board-certified consultant physician since 2020. She has extensive international clinical experience, having served as a clinical fellow in acute general medicine at John Radcliffe Hospital, Oxford University Hospitals, UK, for 2 years, and a Stockport NHS Trust, Manchester, United Kingdom, for another 1 year. In 2023, Dr. Egodage obtained a diploma in medical education from Warwick University, the United Kingdom. Currently, she is actively involved in teaching, research, and clinical practice, contributing significantly to medical education and patient care in Sri Lanka. In year 2023, Dr. Egodage was the secretary of Call Medical Association, and currently she serves as the head of the Department of Physiology, Faculty of Medicine, University of Ruhuna. Today, Dr. Egodage will speak to us on post-viral arthritis, clinical spectrum and current evidence. So I will hand over the to Dr. Egodage to deliver her lecture. Over to you.
Thank you, Dr. Sahan, for that kind introduction, and thank you, Professor Priyamali Jayasekara. So the topic is post-viral arthritis and its clinical spectrum and current evidence. So why this topic is important? And we know like acute or subacute inflammatory arthritis occurring after resolution of viral infection is a common scenario and common thing that we see in our day-to-day clinical practice, which is called as post-viral arthritis. And there's increasing incidence with common and emerging infections. And there's an overlap with early inflammatory arthritis, which makes a diagnostic challenge for the physicians. And it impacts quality of life, but often under-recognized. So with this in context, there's approximately 1% of the subjects with acute onset arthritis who has kind of underlying viral etiology. And also when it comes like to viral infection, if someone presents with viral infection with a skin rash, there's a chance like 31% of them having an arthropathy as well. And the common viral causes, as you know, could be alpha viruses like chikungunya virus or parvovirus B19 and many other viruses that we know can cause viral arthritis. And according to geographic distribution, for example, alpha viruses also could vary and from different areas or the different regions of the world, you might find different types of alpha viruses. But I would not going to go into details like a typical lecture. I thought of going along kind of burning questions that physicians could have regarding viral infection. So I'm going to answer some questions that I thought would be helpful to understand post-viral arthritis. And my first question is, what is the current evidence for viral persistence in muscle or synovium? And does persistent replication contribute to post-viral rheumatism? Because it's important to understand that this because we heard or there's a discussion that there's active viral replication in the joints, even when it comes to chronic rheumatism. So that some discourage use of steroids because steroids can worsen the viral replication because of the immunosuppression associated with that. So whether there's any evidence for this, whether there's active viral replication in the joints and muscles when it comes to this post-viral arthritis. That is one question I'm going to answer. Next is, what are the common clinical patterns of post-viral arthritis? And do different patterns require different management approaches? Day-to-day practice, we see different types of patterns, like, some have mainly axial type of pattern, some having only small joint involvement, some could have combination of this, some could have mainly enthesitis rather than joint involvement. So when we are going to treat these patients, should we treat them differently? That is another question I'm going to answer. When should we suspect an autoimmune process and request an autoimmune arthritis panel? Sometimes some patients are having kind of very chronic type of rheumatological illness associated with post-viral arthritis. And we find it extremely difficult to differentiate it, whether this is really evolving into rheumatoid arthritis or spondyloarthritis. Is this kind of viral infection precipitating an underlying arthritic trend or autoimmune process this patient had previously? Or the other possibility is whether this is kind of, there's autoimmune panel, whether it's getting positive because of underlying inflammatory process. That is another thing that could be there. Or this is just the chronic rheumatological condition as a result of just the post-viral infection and the inflammation which it induced. Not really kind of rheumatoid arthritis or involvement in rheumatoid arthritis or spondyloarthritis. So in that context, at which point should we do the tests to check whether there's an ongoing autoimmune disease or not? And then a lot of controversies regarding NSAIDs are there. So we are reluctant to use NSAIDs during the first 1 week or so, and at which point we are going to start them on NSAIDs. Is it just after excluding dengue? Can we reliably start them on NSAIDs? That's another question. And then would NSAID suffice, or should we add on corticosteroids on top of that? That is other question. And then do we have reliable high quality evidence? And then when should we escalate them to DMARDs? And do we have evidence that DMARDs would help these patients? Why we should start them? How early should we start? And what is the typical clinical cause of these patients? Can we, like when we see these patients during the first 1 or 2 weeks, can we give them the prognosis of the disease, whether they are going to develop this disease for this long, or whether they would improve within few days, whether we are able to give kind of discussion, whether we can have a kind of discussion with the patient regarding those facts. So these are the questions I'm going to answer during my lecture as much as possible. Maybe I would not be able to answer all these questions. There may be still queries in certain areas. So my first question, what is the current evidence of viral persistence in muscle or synovial? And does persistent replication contribute to post-viral rheumatism? That is my first question. So for that, we should have some idea about the pathophysiology of viral arthritis. So as we know, with any other disease, in this disease also, we have the host factors as well as the factors related to the virus as well when it comes to the inflammation or whatever the reaction that it would create, right? So autoimmunity is the main mechanism in the post-viral arthritis. So it's not like the typical autoimmunity that we know, but autoimmunity is like, if the self-tolerance is reduced, we call it like that can trigger autoimmune process. So that is what viral infection is doing. So how does it do that? It triggers autoreactivity by different mechanisms. If you could remember, like these are the antigen presenting cells, which are presenting the viral antigens. The green color are the viral antigens to the T cells, right? And these T cells are increasing in number, and these autoreactive T cells then go and attack the self antigens, right? They could not identify them as self antigens, so that it could trigger an autoreactivity. And this mechanism, we call it molecular mimicry. So for example, this is what we see in our rheumatic fever patients, and this is what we see in, for example, Guillain-Barré syndrome, the molecular mimicry, and which can attack the tissues, and then the damage occurs. And similarly, the bystander activation. So that is when these antigen presenting cells are presenting these viral antigens, Along with that, self-antigens will also be presented at last, so that the autoreactive T cells will get activated for self-antigens as well. So we call it bystander activation. And then not only that, there will be epitope spreading. Epitope spreading means there's multiplication of these responses. Different tissues containing similar antigens will implement the autoreactivity, enhancing the inflammatory process. So from these mechanisms, the viral antigens would trigger autoreactivity in these patients. And not only that, our main question, whether this impaired clearance of viral antigens, would it lead to trigger autoreactivity? Yes, it would lead. But is it just the virus or is it just viral antigens? So arthritogenic viruses demonstrate tropism for synovial tissue, which is true. And but the synovial fluid cultures could only isolate parvoviruses and enteroviruses. And when it comes to chikungunya virus, they found it only in synovial macrophages and in the muscle fibroblasts and myofibers. But they could only find viral RNA. They couldn't find the replicating viruses inside these muscles or joint synovial fluid. However, the autoreactivity can be triggered by these ongoing immune reactions due to the presence of these residual viral materials, even though this researchers have not found any kind of active viral replications in these tissues. And as well as genetic susceptibility would play a role. And also the humoral responses, that is the antigen-antibody reactions and deposition in the joints, which could activate complement pathways and leading to destruction of the joints. And also, when it comes to the chronic rheumatism associated with viral arthritis, they have found the regulatory T cell deficiency in these patients. So there's kind of unregulated T cell activation, which would lead to cytokine activations like interleukin-6, TNF-alpha, interleukin-10, and many other interleukins and cytokine activation. And also they found the patients who are recovered from chikungunya have favorable CD4 plus T cell activation with interferon gamma mainly released, while the patients who have ongoing chronic arthritis have TNF-alpha mainly secreting type of CD4 plus T cells. And let's come to the second question. What are the common clinical patterns of post-viral arthritis, and do different patterns require different management approaches? So the management approach, I will discuss about it later. But first I tell what are the common clinical patterns they have found in different regions. So the post-viral musculoskeletal syndrome has articular rheumatological manifestations, which are involving mainly joints. They can be acute or subacute onset, can be arthralgia or arthritis. And joint involvement is often symmetrical and polyarticular. And there can be still oligoarticular and monoarticular patterns as well. And some patients would develop decompensation of pre-existing arthritis. And this shows some patterns of, you can see this India, Brazil. Brazil is the main country that the research, most of this research are originating from Brazil. India also, they also have some amount of research, but mainly very reliable and good type of evidence coming from Brazil. And you can see the involvement of joints in acute chikungunya and chronic chikungunya. Unfortunately, they could not grasp the pattern of India when it comes to chronic chikungunya, which would be closely related to the pattern we see. But you can see when it comes to chronic chikungunya infection, you can see mainly there's involvement of hands, ankles, vertebral involvement could also be there. So you can see like there can be axial involvement as well as there can be small joint involvement. And not only that, like in acute, subacute, as well as chronic stages, we see many extra-articular or peri-articular rheumatological manifestations. So they can be either enthesitis, like tenosynovitis, or tendinitis. In this picture, it is shown like one patient having tenosynovitis with a small nodule as well. And tenosynovitis is extremely common. And then fasciitis, like plantar fasciitis, or capsulitis, like shoulder joint capsulitis, or periostitis sometimes. And then this is showing chronic Achilles tendinitis. And another thing these patients develop is this reactional edema. And entrapment neuropathies can be seen, like carpal, cubital, or tarsal tunnel syndromes. Maybe that is mainly associated with these reactional edemas. And some patients develop neuropathic pain. They found like about 20% of patients are developing neuropathic pains, like pins and needle sensations, neuropathic pain features, and also paresthesias, myalgias, and fatigue, and sometimes rarely Raynaud phenomena as well. So these are extra-articular or peri-articular manifestations that are associated with viral arthritis and mainly chikungunya arthritis. So as I described, right? So this is the classification, the big whole classification of arthritic illnesses. So when you see this, to which categories can we put these patients, the post-viral arthritis patients? So this is, we can categorize them, we can put them to seronegative arthritis definitely. And they can have sometimes rheumatoid arthritis pattern, which is still should be seronegative, or it can be spondyloarthritis pattern. The spondyloarthritis pattern, some may have mainly axial spondyloarthritis pattern with the back involvement, and sometimes they can have peripheral spondyloarthritis pattern as well, with peripheral joint involvement with some tendinitis as well. And the various research resulted in, like in 2025, they have done a meta-analysis, and they found about 58% of this is about chikungunya mainly. 58% of individuals with chikungunya virus infection develop chronic arthropathy. So this is like they have taken multiple studies from all over the world and found that it is approximately 58% when they analyze. And then they said like about 14% of them have clear rheumatoid arthritis pattern, 13% spondyloarthritis pattern, and 5% ankylosing spondylitis pattern. And how did they categorize them? That is according to the classification criteria for these different types of arthritis. When they classify, they found that there are classical features and that they can categorize these patients into these different types of arthritis. And then the issue, is it only arthralgia, or is there a component of erosive arthritis which warrant DMARD treatment? That is why for rheumatoid arthritis, we start DMARDs early. That is because we know in the early, we learn when we learn about rheumatoid arthritis, it is early in the disease, more erosions occurs. You see more radiological disease changes early in the disease. So we have to start DMARDs as soon as possible. But we can't say it when it comes to post-viral arthritis, because not all the patients are not developing erosive arthritis, but some of them, they found as developing erosive arthritis. Some patients, even after 10 years of the disease, even sometimes they have only joint pains, but the x-rays and the radiological findings were supportive for erosions. And not only that, the synovial inflammation, cartilage destructions were also seen. So this highlight whether there's a need for DMARD treatment if you see a pattern of kind of rheumatoid arthritis pattern in these patients. So that is important. So this is again showing how long it can go. Like, so you can see it's a 49-year-old female who was on steroids as well, but still having soft tissue rheumatism ongoing for years. And here also another MRI finding showing that there's edema as well as bone erosions ongoing in patients. So it is pretty obvious that there can be bone erosions when the pattern, like if there's a severe type of pattern and if it persists for a long period. And not only that, there can be sometimes like some polymyalgia rheumatica like clinical patterns, and the patients are mainly complaining of myalgias. So when it comes to myalgia only type of disease without much of synovitis, then you have to consider whether there can be any other condition like statin-induced rhabdomyolysis, or the patient is having depression or fibromyalgia in your differential diagnosis. Right. And then the question is, when should we suspect autoimmune process? And when should we ask for autoimmune arthritis panel? When it comes to like the first few weeks of post-viral arthritis, where the inflammation is ongoing, the patient is having typical inflammatory arthritis. Sometimes there's a risk if we do the autoimmune panel that it can become positive, maybe vaguely or mildly positive because of the ongoing inflammation, even without having clear pattern of clear rheumatoid arthritis pattern. So why we are doing this is, one reason is sometimes this is a viral infection precipitated type of underlying kind of the trend. The patient had had kind of underlying risk factors for rheumatoid arthritis, and the viral infection has precipitated that. So we want to clearly identify this, whether this is rheumatoid arthritis or spondyloarthritis now. So we have to consider this early, like if there's persistent synovitis more than 6 to 12 weeks and very high inflammatory markers and erosive changes on imaging, and if there are extra-articular manifestations like manifestations of psoriasis or inflammatory bowel disease, or if there are constitutional symptoms. And you can see here, if the infection is ongoing, in the chronic phase, they recommend like after 3 months to do the rheumatoid factor, anti-CCP, and HLA-B27. Depending on the pattern the patient shows, you can ask for any kind of autoimmune panel, autoimmune disease screen investigating type of panel for that patient. And then the question is when to start NSAIDs. Is it only because of dengue overlap that we are not starting NSAIDs at the initial period of the disease? So here I'm going to compare some very well done kind of guidelines, because when it comes to this post-viral diseases, we can't find many randomized control trials. Even the randomized control trials we see about less than 50 patient participation, like 20, 15, 30 type of participation. So, but the guidelines have taken the knowledge from some randomized trials, and also they are going along with expert opinions. So, one of the latest guidelines we find from India, and the Sri Lankan guideline has been recently released. The Sri Lankan guideline is mainly based on Indian and WHO guidelines. Those are the things they have given as references. Maybe there's some expert opinion in that as well. And the Indian guideline, they emphasize that paracetamol, hydration, and avoid NSAIDs until dengue is excluded. And so they say mainly that once the dengue is excluded, you can start NSAIDs. When it comes to Brazil guideline, which is updated in year 2020, they still say paracetamol is the first line during the acute phase, and you can use NSAIDs after excluding dengue, and they are asked to avoid steroids because that can worsen the underlying viral infection. So it is kind of similar in all guidelines actually. They are asked to avoid NSAIDs until the dengue is excluded. But here you can see, this is the Brazilian guideline, 2020 updated version. Here they say do not use NSAIDs and acetylsalicylic acid at acute phase due to the risk of complication associated to severe form of chikungunya. So not only because of dengue, they are again emphasizing that chikungunya, but I couldn't find this actually in other research, that chikungunya can worsen can have a worse, like the severe forms, and those severe forms, there can be renal involvement. You know, NSAIDs are definitely not good for the kidneys, and also it increases the bleeding risk with in different ways. So that it is better if you just think it's chikungunya, still to avoid NSAIDs up to around 7 to 10 days, right? So that is the current evidence. So what can we give for these patients in the acute disease, right? So if we can't give steroids, if we can't give NSAIDs, so can we just manage with paracetamol? We don't have dipyron, which is available in some countries, which is a weak NSAID, which they ask to continue without a problem, but we don't have it. So for severe pain, we have to rely on things like codeine or tramadol. And they say the other thing is, if there's neuropathic pain features, if you, like the patient is telling pins and needles and neuropathic type of pain, then to do the DN4 questionnaire and confirm it and give neuropathic pain tablets, that is like pregabalins, gabalins, gabapentins, and amitriptyline type of medications. So this is the other score they are asking to do, that is the visual analog scale to assess the pain of the patient, if possible. And then the other thing is this neuropathic questionnaire. And if the neuropathic questionnaire shows more than 4, the score is more than 4, they ask to start these medications like amitriptylines and gabapentins for the patients. But in experience, we find that patients sometimes respond to these pregabalins along with paracetamol during the acute phase, because that is the option we have, because NSAID, we can't prescribe NSAIDs at that stage. So not only that, when it comes to Sri Lanka especially, we have so many patients, we see, like not only in Sri Lanka, in other countries where dengue prevail, we see co-infections with dengue and chikungunya. So there's a risk, right? That even though like you feel like the joint pain is there, so this can't be dengue. There's very severe joint pain, synovitis is going on, tendinitis is there. Still, there's a risk there can be co-infection with dengue. So that symptom cannot exclude dengue, right? And the other thing is dengue patients can also have some amount of arthralgia, but it is not that prominent when compared to chikungunya, but there's still a possibility there's a co-infection. So if there's a co-infection, you have to always treat the patient as dengue, because dengue is the one which can commonly go into an acute and severe or critical illness during the acute phase. So can we, like when the acute stage is over, when it comes to subacute phase, can we give NSAIDs alone, or should we combine it with corticosteroids? If we are combining corticosteroids, should we start it with low dose or high dose? Or is there a rationale of giving high dose steroids plus NSAIDs? Can it increase the risk of bleeding and things? So when it comes to the subacute phase, many guidelines offer starting steroids. Indian guidelines says you can start steroids with low dose, 10 milligram per day, along with NSAIDs. Or else they also say, if you like, you can start it from slightly higher dose, like 0.5 milligram per kilogram. And the updated version of Brazil, the guideline, they say also you can start steroids with very kind of high dose, 0.5 milligram per kg, so like 30 milligram per day dose. The guideline is slightly older compared to the Brazilian and Indian guidelines, where they offer corticosteroids plus or minus NSAIDs, and there's a place for hydroxychloroquine during this at this phase. When you want to stop steroids for patients, you can check whether you can continue the patient with hydroxychloroquine. So there are some, but for the chronic phase, sometimes they argue it doesn't have much of benefit. But subacute phase, if you start it, sometimes you may be able to continue it. And HCQ has less side effects, and it is very convenient for a physician or a junior doctor to continue HCQ because it doesn't need much of monitoring. And if you start it during the subacute phase, that would be helpful for the patient to continue with while stopping, if possible, stopping NSAIDs and steroids early. I don't know whether this is very clear to you. So this is a guideline I really like. This is the Brazilian guideline, where they say if there's only localized or diffuse non-inflammatory musculoskeletal pains without arthritis, they still say you should start NSAIDs, right? But they say if there's a risk that they can't start NSAIDs, you know, some patients, if someone is having chronic liver failure, you can't give NSAIDs. If someone is having even mild renal impairment, NSAIDs are completely contraindicated. You can't start. So in that case, then you have to go for other analgesic options, right? But otherwise, you can start NSAIDs, right? You can start NSAIDs, but you have to check whether you can reassess, whether you can continue it after 2 to 4 weeks. And then if there's arthritis or tenosynovitis, then they now recommend, this is not like their 2017 guideline said, that's you can start NSAIDs plus small dose of steroids. But now they have completely omitted NSAIDs and they are asking to start from kind of 0.5 milligram per kilogram per day type of a dose. Maybe this is too much. Most of our patients would be able, I think we would be able to manage with much lower dose. But this is the dose, maybe that depends on the severity of the disease. And then they are continuing it in the same dose for 4 weeks. And if the pain persists, they would continue it, or they would have to do, they say that we have to go for other options. But if the pain is subsiding after 4 weeks, they are asking to reduce the dose every week by quarter of the dose, the quarter of the initial starting dose. And usually, if there's neuropathic component, they advise to give amitriptylines, gabapentines to the patient. So NSAID treatment. So NSAID treatment, I mean, different people give NSAIDs in different ways. Like rheumatologists are like kind of bit liberal and they give NSAIDs for long durations. I think we as physicians, we are a bit reluctant to give NSAIDs because we know we can see like the complications. And then if it comes to nephrologists, they are much reluctant to give NSAIDs to patients. So NSAID use it should be always reassessed after 10 to 10 days or 14 days, because even though it's a young patient, there can be patients who are sensitive to NSAIDs. It's not only the well-known GI side effects, the renal side effects as well. If the patient doesn't have comorbidities like ischemic heart diseases, or the patient doesn't have any renal involvement, sometimes with caution, you can continue NSAIDs for some period. But you know, the COX-1 or COX-2, they have their own complications. Like when it comes to COX-1, there's bleeding, perforation, GI ulcers type of things. And when it comes to COX-2, stroke, thrombosis risks are high. And both types of NSAIDs increase the renal risk, fluid retention, and renal impairment, and the afferent arterial constriction, and reducing the glomerular filtration rate. So you have to be very cautious when you are starting these things to elderly patients, especially, and the patients with comorbidities. So that is the problem with NSAIDs. And when it comes to steroids, we have another problem. If the patient have diabetes, if the patients are having ischemic heart disease, still there's a risk of starting steroids for those patients. So adding steroids, after reading all these recommendations and everything, we can start steroids early only for the patients who have associated soft tissue rheumatism, like tendinitis or synovitis, which are very resistant to the treatment of NSAIDs, and they indicate severe form of the disease. But otherwise, if it's just arthralgia, we can continue with NSAIDs. If there's tenosynovitis, tendinitis, plus severe form of arthritis, it's better to start steroids and NSAIDs at the same time. Which dose you could start, you can think about the disease severity and how the patient respond to the treatment. And when it comes to Indian guideline, They said to start initially 10 milligram per day for 5 days and then reduce the dose. And then they say if there's a severe presentation to go for 0.5 milligram per kilogram per day dose. And then after 3 to 5 days, they are asking to tail it off, not like the Brazilian guideline where they say like to continue it for 4 weeks. And then this is Sri Lankan guideline. There it says 10 to 15 milligrams per day of steroids would suffice. And also they say that giving NSAIDs and steroids would be risky because it can increase the bleeding risk, especially gastrointestinal bleeding risk. Right. So when should we escalate to DMARD therapy? And what is the most effective DMARDs in the chronic phase? So this is like a very congested slide. So I wanted to show that there can be different patterns as I discussed it previously. If these criteria are fulfilling, that maybe the patient is strictly showing rheumatoid arthritis type of pattern. And then spondyloarthritis pattern, some of them like 50-50 when it comes to chronic arthritis, these patients you would see. But sometimes the undifferentiated polyarthritis patterns would arise. That is the question, that is the problem. Because like for rheumatoid arthritis pattern, you can say like just we can manage as rheumatoid arthritis patient when we are starting DMARDs. Spondyloarthritis, yes, it's easy. But when it has both features, it's a bit difficult, right? So here, this is something like we all should know, like if we are treating arthritis, especially post-viral arthritis, because patients can have axial SPA type of pattern, like mainly involving the vertebra and then sacroiliac joints in some patients, or maybe peripheral arthritis pattern that can be associated with SPA type or with just the peripheral arthritis pattern or enthesitis. So if we come to methotrexate, like the methotrexate, it has some benefit for axial SPA, but not the best. It is best for peripheral arthritis and has some benefit for enthesitis. And leflunomide, it doesn't have much benefit for axial, but peripheral arthritis, it's good. It's like kind of similar to MTX. And enthesitis, it shows some benefit. And when it comes to sulfasalazine, it is not improving axial SPA, but SPA's spondyloarthritis, if the peripheral pattern of it, like for the large joint involvement, kind of peripheral pattern of spondyloarthritis, those symptoms can be improved with sulfasalazine. And enthesitis also, it has some benefit. When it comes to hydroxychloroquine, it is not very effective for any of these things, but it has some benefit for peripheral arthritis. And it is shown that MTX has benefit for all 3 types of long-term rheumatological manifestations seen in post-viral arthritis. So more than 3 months chronic phase, if you compare the guidelines, you can see France, even though it's an old guideline, they are straightly recommending methotrexate for their patients. And but other guidelines, WHO is asking for the rheumatology referral first hand. Brazil and India are mainly telling you can first try hydroxychloroquine and sulfasalazine. If it fails, go to methotrexate. This is the updated version of Brazil guideline. The Brazilian guideline, here they say, if severe or moderate disease involvement more than 5 joints, moderate to severe edema and pain. So that is, if it is severe disease, straightly start on methotrexate. And then reassess after 8 weeks. It is too long. I think we have to reassess before that. But this is kind of, I think, more helpful and has more evidence in it. And if it is less severe, I like this as well. You can go for hydroxychloroquine, because hydroxychloroquine is relatively a harmless drug and we can keep the patients on. And this is how the methotrexate again, like they asked to start from 10 milligram and go up to 25 milligrams as usual, weekly doses. And research show that there's good benefit of methotrexate. This is a patient who has been treated with methotrexate and showing drastic improvement of the joint involvement. And when it comes to hydroxychloroquine, not many guidelines are for that. They are telling, but there's only one randomized trial comparing hydroxychloroquine with other drugs, but there they gave a combined treatment, methotrexate, sulfasalazine, and hydroxychloroquine together, all three together, and compare it with hydroxychloroquine, which is very unfair by hydroxychloroquine. So I think it is good option that we all should try, because I have seen some patients only on hydroxychloroquine and improving with that. And when it comes to the cost issue, still the methotrexate, if it is like the hospital based or outside, wherever, methotrexate is very, very cheap. Even though like you are giving 4 or 5 or 6 tablets together, still it is very cheap. You are taking it only once per week. When it comes to leflunomide, sulfasalazines, and hydroxychloroquine, all three actually, like when it comes to the maximum dose of them, they are kind of in the same range. For example, leflunomide, we start from 10, go up to 20. And then the cost-wise, it is similar to sulfasalazine. Sulfasalazine also, even though we started from 500 milligram BD, that is not the optimal dose. It is a suboptimal dose. It should be 1 gram twice daily. And hydroxychloroquine, we can continue 200 milligram daily, and some recommend to go it up to 400 milligram daily. Still, it is also slightly expensive, and all these three are in the same price range. And safety issues wise, actually hydroxychloroquine is better. And when it comes to monitoring, you have to do a baseline ophthalmologic examination. Maybe like you don't need to do it for every patient. It is recommended though, but you can do it mainly for elderly patients who are complaining of vision issues or anything like that. And then only 5 years after, after on HCQ, we have to do annual screening for the retinopathy. But otherwise, you don't need to do much monitoring for that. But all three, methotrexate, sulfasalazine, leflunomide, you had to do baseline full blood counts, liver functions, creatinines, and then you had to repeat it after 2 weeks ideally, or 4 weeks. And then each time when you increase the dose, and every month, and you know, STLT is also quite expensive. So the monitoring is an issue. And when it comes to leflunomide, teratogenicity is an issue. You can't start it on young patients. It has a significant teratogenic side effects. And if they want to become pregnant, they have to be off treatment for at least 2 years. So it's complicated. And the other thing about leflunomide is it's a nice drug, works really well, but the blood pressure. If someone is having hypertension, it will go into an uncontrollable hypertension when you start leflunomide. Right. So I would say SPA-like presentation, I would go for sulfasalazine, especially if they're to tackle their peripheral joint involvement, starting with 500 milligram twice daily, going up to 1 gram twice daily. And then methotrexate also could be started with proper monitoring, and leflunomide as second-line option, and hydroxychloroquine, depending on the patient. If it's a milder version of the disease, the patient can be continued on hydroxychloroquine. And then what is the typical clinical course? My last question. And can we reliably discuss prognosis with our patients? So this is a question because most of the patients defaulting from the treatment. So we start them on steroids, we start them on NSAIDs, and then sometimes we start them on DMARDs, and then they default treatment, and then they are coming with another flare-up. So at the onset of the disease, within the first 1 to 2 weeks, if we can tell them this is the cause you are going to get, it would be really helpful. Do we have any evidence for that? Are there studies in literature? Thing is, studies measuring chikungunya antibody levels, when we talk about chikungunya. They are antibody titers. They could not find any correlation of arthritis severity, flare intensity, pain, disability with the antibody levels. So that means this humoral immunity, like the antigen antibody depositions and activation of the complement pathway and joint destruction through that, is not really driving this arthritis process, right? So it is not really correlating with the patient's severity of the illness or duration of the illness. And autoantibodies like rheumatoid factor, anti-CCP, anti-CEP1, say like if they are positive at the onset, still they found that it is not actually correlate with the severity of the disease. As I said, when the inflammation is too much, sometimes these things can become weakly positive, but they still couldn't find any correlation with that. And if there's any prior exposure, like the recent exposure to dengue or any kind of arbovirus infections, still they couldn't find any correlation that it would add something for the disease severity. And some studies are giving like very not really reliable type of associations with this disease severity. If someone is more than 45 years, female, and at the onset, if there's severe pain, presence of edema, polyarthritis, rigidity, and previous joint disease, having diabetes, and CRP, elevated CRP at the disease onset, or persistently elevated immunoglobulin. But these are like controversial. Some like these are not like actually because of number of patients are low in these studies, we can't completely rely on these studies. So we are still lacking evidence for the predictors for chronic progression of the disease. So in summary, right, I try to answer certain questions that the physicians or our younger physicians would have, our PG trainees that they would have, or our general practitioners could have during their when they are managing post-viral arthritis. So if I summarize what I have discussed so far, I said that viral causes account for roughly 1% of acute onset arthritis. So asking the question about the virus etiology is important from all the patients coming with even with symmetrical type of clear rheumatoid arthritis type of pattern. And then persistent viral RNA rather than ongoing viral replication is thought to drive chronic arthralgia in several viral infections. So we know there's no contraindication to start steroids. We are avoiding steroids early at the early disease because the viral infection is ongoing, not clearly if it is not in the joints like in the body. So we can't give them steroids initially. But later on, there's no contraindication for this joint arthritis to arthritis patient to stay on steroids. And recent evidence suggests that impaired regulatory T cell function contribute to chronic viral arthritis. So this is a possible way of like doing research. There's a way forward in this when it comes to post-viral arthritis. If we can investigate more on that, we may be able to develop an effective medication for them. And another thing I didn't tell you is like if the patient is not responding to methotrexate, you can go to the triple treatment as usual, like sulfasalazine hydroxychloroquine with methotrexate. If they are still not responding, we have to refer them to the rheumatology for a biologic treatment, which may be effective for these patients. More than 50% of individuals infected with chikungunya virus develop chronic arthropathy, and which can persist thereafter for months to years. And progressive joint pain and radiographic changes after chikungunya infection emphasize the need for early initiation of DMARD therapy in persistent arthritis. And autoimmune arthritis screening is recommended if symptoms last beyond 3 months. Because of the lack of randomized control trials and the small sample sizes in existing clinical studies, current management recommendation for post-viral arthritis rely heavily on expert opinions rather than high-quality evidence. And methotrexate is useful across multiple patterns of post-viral arthritis, including symmetrical polyarthritis, oligoarthritis, and enthesitis dominant diseases. Reliable predictors of severe or chronic outcomes in viral arthritis are not yet firmly established. So that is the summary of the discussion. And thank you all for listening. And I would like to specially thank my friend in rheumatology, my co-registrar, who is a rheumatologist now. And we were discussing about all my slides throughout. That is Dr. Anushka Edirivira, rheumatologist in Ratnapura Hospital. Thank you very much, Anushka, and thank you very much, for giving me this opportunity. And thank you very much for listening.
Okay. Thank you very much, Dr. Udari, for that excellent and comprehensive presentation. I think the audience learned a lot, and thank you for the insights given in diagnosing and managing, especially management of post-viral arthritis. I think we have a couple of questions in the Q&A. So we are moving on to the Q&A session. And at the same time, I would like to share the QR code now to for the audience. I think all of you can see that. Dr. Udari, can you also see this? Can you see the?
QR code.
Yeah, I mean, I just want to know whether
Yes, yes,
everyone
can see.
is. Okay, madam. Thank you. So the participants, so you can scan the QR code shown here, and I will also post the uh, Google link for the Google form. If you scan the QR code, you will access the same Google form, and you can fill the details to get the CPD e-certificate. Probably you will get it within 2 weeks. So this will be displayed for some time, and in the meantime, we can take the questions for discussion. So I think we in the Q&A box we have questions. Dr. Udari, would you like to go through
Question is,
those or shall I?
can we
Yes.
start NSAIDs patient with dropping platelet count? Dengue excluded patients. So that is what I discussed, because it's not only because of dengue. They say that the chikungunya has a severe form, which we do not see in many patients, though, that could lead to renal impairment, low blood pressures, and bleeding. So there's a risk if we start NSS during the first week that they can go into the severe form. I mean, this is like not really research-based thing. That is what they imply, especially in Brazil. That is what they say. So I think it's better to avoid NSAIDs at least for 1 week, depending on that. But I mean, if the platelet count is very stable and is like the patient is fever-free, then you can start NSAIDs reliably to these patients. What would be the treatment for chronic joint pains following chikungunya despite having normal? There's no problem with the inflammatory markers here. So you have to treat the patient even though the inflammatory markers are normal. So as I said, like if it is only arthralgia and muscle pain you see, still there's a place to give NSAIDs for those patients. But after 2 weeks, you can reassess. If they are improving, you can stop it. But if it persists, then you can consider adding steroids or HCQ to that patient. But inflammatory markers are not guiding you. So you don't need to rely on inflammatory markers, or either you don't need to actually, like if you find it very high at the onset, you can just continuously check that. But otherwise, there's no indication for you to monitor the inflammatory markers. And this is, I think, if there's PCM allergy, what should give until exclude dengue? I think for any dengue patient, you could have that problem. But if you think you want to manage pain, here, what I would give them is a small dose of pregabalin, because it really works well for their pain. They could have neuropathic pain or they would not have neuropathic pain. If you don't have any other option, if they can't tolerate codeine plus paracetamol, and we don't have codeine only prescriptions here, so what we can go for is a pregabalin or gabapentin. What is the chance of having spontaneous relief of post-chikungunya arthritis without these drugs if you have arthritis? So it is a complicated question. I mean, whether you should really treat or whether we would ask the patient to stay like that, like just tolerate that is the issue, like because pain management is a huge topic. So if someone says, I don't want to take tablets, I would live with this. that's okay, because steroids or NSAIDs would not going to change the disease process of the patient, right? Even if it comes to rheumatoid arthritis, it is that if you're starting a DMARD, that would change the chronic nature of the disease or erosive nature of the disease. Steroids or NSAIDs is just managing the patient's mainly the pain component, though it's like attacking the inflammation and reducing inflammation. By that also what they do is reducing the pain. They are not going to change the disease process as such. So I would say like it depends really on like where you are going. Like it is like pain management, but if if the patient has really a severe form, with the decision of starting DMARDs is the main decision, because that is the one which is going to change the prognosis of the patient. And like if I tell like if someone is having joint pain and living with that, I would not be like, I mean, they are tolerating that, and like I would advise them to start on NSAID or steroids, because if someone is having joint pains, that can share that would not that would reduce their quality of life. And the other thing is, if they are like not moving well, and if they are limping because of that, that could cause damage to the other joints as well. And this patient who is having plantar fasciitis and you are not treating that, and the way he walks, at last they will have joint damages and joint pains ongoing in other joints as well because of the asymmetric pain distribution. So I would advise someone, like we could encourage them to stay on NSAID and steroids, but they are not going to change the disease course, but the patient's pain management is important. I think for the next one is also the plantar fasciitis. Maybe they would, I don't know exactly, but I think they would improve it some with time. But I think steroids and NSAIDs would be helpful to keep the quality of life. Do post-viral arthritis have very high ESR, like more than 100? I have never seen. Because even with rheumatoid arthritis, it's very rarely we see ESR more than 100, but rarely it can happen. With PMR, the ESR can go above 100. I'm not 100% sure about that because I have never seen. Is there a place for steroid in acute phase post-viral arthritis, oral or IV? There's a place, but we are not giving that because the acute viral infection can exacerbate and worsen because of that. If someone is having neuropathic pain, what they ask is to do the DN4. You can Google it, DN4 questionnaire. And if the neuropathic pain is more than 4, to start neuropathic pain management along with steroids and NSAIDs. So only that, depending on how bad the patient is. So neuropathic is like, pregabalins, gabapentins. They are renal friendly. They don't have many side effects other than these patients, they might feel drowsy, or maybe they develop postural hypertension. There's a slight fall risk associated with them. But otherwise, renal and liver wise, they are most of the time okay. So that depends on the neuropathic pain scale. There's no evidence for calcium supplements in post-viral arthritis. But if the patient has ongoing persistent muscle pains, as I told you, you can say whether it's statin-induced, whether this patient is kind of depressed, or whether this is fibromyalgia, or else whether there's underlying vitamin D deficiency, calcium deficiency, these things, or hypothyroidism, these type of things, I think you can actively look into. Local NSAID creams, I'm not relying on them. I don't know, maybe like hot fermentations and NSAID creams, people are using them, but I'm not usually recommending. It could give some psychological benefit, but I'm not 100% sure about that. I don't think there are studies. Sulindac. For kidney disease patients, if there's severe pain, one thing you can try is colchicine, because there's some evidence for colchicine as well for, gout patients also, because we can't give NSAIDs for kidney disease patients. Sometimes we give colchicine. So if the kidney disease patient is not due to diabetes, we can start them on steroids. But you can't definitely give NSAIDs. This Sulindac thing is now, I think, out of fashion. That was one era that they were prescribing Sulindac for these patients. So you can use steroids for these patients, and you can give gabapentins, pregabalins for these patients, and you can try colchicine. Yeah, chronic arthritis patients, they can develop post-viral arthritis on top of that. Then the thing is, like, if the patient is on methotrexate, you have to stop methotrexate at that point. And once the patient's acute viral infection, when they get away from that, only that you can restart them on methotrexate. So that is an important information. So certain DMARDs you have to stop at the onset of the disease if someone with non-patient with rheumatoid arthritis while on DMARDs developing viral arthritis. Chronic phase of chikungunya, yes, you have to do the IgG test. Then chikungunya IgG test, you can reliably diagnose that disease due to chikungunya. If the symptoms are improved, you don't need to continue the drugs. We can tail it off. But in case if methotrexate is started to the patient, so that decision is a huge decision. You thought a lot to start methotrexate to a patient. That is because of the severe or chronic nature of the disease, methotrexate has been started. Then it is better at least to continue it to 3 to 6 months period. Certain studies said 3 months methotrexate staying is quite enough, and then you can tail it off. But like, because that decision is a huge decision that you made because of the chronic nature of the disease, there's a risk of relapsing when you stop methotrexate. Then again, you have to start them on prednisolone and bridge methotrexate treatment and restart again. To avoid that, you can keep on methotrexate 3 to 6 months before tailing off the dose. I think I have answered all the inbox questions, Sahan.
Thank you very much, Dr. Udari. I think one other thing we should emphasize is that we should not give two NSAIDs together at the
Definitely
same
not.
time.
Yes.
I
But in
think
the
that also,
guidelines, they said like if one NSAID is not working for a patient, you can change it over to another NSAID, but definitely not two
yes,
NSAIDs too.
yes, I think some have that practice as well. That's why. And yes, and I think we have a very fruitful session, and I think we got many questions from the audience as well. And I think one last question came in the Q&A. If I can forward that, are there thoughts of evidence on exercise
Yeah.
in
So they don't tell
physiotherapy?
anything about specific exercise, but they recommend physiotherapy. So we can't do the exercise that we like. I think that there should be expert opinion on exercise and do that, right? Physiotherapy has a role.
So thank you very much again. I think for the audience, I think it was a very fruitful session today, and also we gathered many insights into the management of post-viral arthritis. So on behalf of the Sri Lanka College of Internal Medicine, I should extend my sincere gratitude to our speaker, Dr. Udari Egodage, for delivering this excellent speech today. And also Professor Priyamali Jayasekara for giving the introductory address and being with us today. And I must thank all the participants who have actively engaged in forwarding your questions, and also, I think, giving your fullest attention to this valuable content that was delivered today. So I think with that, we can conclude our session today. So I wish you all a very good night until we meet again in the next chapter in January. Thank you very much.